Basically, the objective is to understand some of these chemical agents, what they do, their toxicity, and management and recognition of some of the chemical weapons or chemical agents that can be used. And I'm going to mainly stick to the topic of chemicals. There's one thing that Dr. Marks brought up about the Japanese and their anthrax bomb. Just might mention that there was a Japanese surgeon, his name is Shiro Ishii, who in 1932 started working with those biologicals after China was invaded by Japan. And he started a very sinister research effort using captured prisoners to test these kinds of agents on. And, excuse me, they actually developed these biological bombs and used a plague bomb on October 4th, 1940 in Shanghai, or rather in one of the provinces of China. And so the Japanese had already developed a lot of these sort of weapons. So I can understand where, when he said that we dropped a nuclear weapon at that time, the Japanese had spent about 10 years already developing these bombs and had used them several times on people. So those things historically were around, and I think the United States probably did find out about that. For the chemical weapons and chemical agents, the modern history shows that the first use of a chemical weapon occurred in World War I on April 22nd, 1915. And that was the date that's accepted as the beginning of modern chemical warfare weapons, when French and Canadian troops were huddled in these trenches, and the Germans released chlorine gas into these trenches. They soon came to realize the wind blows different directions and so forth, and the chlorine wasn't very effective. And so they eventually shifted over to phosgene gas, and then to mustard gas. So really the development of the chemical agents came as a result of a lot of research efforts in World War I, continuing up through World War II. And the years between 1914 and 1918 were known for their development and chemistry of war gases. There is a book that's in the library. It's a 1939 publication by an Italian, Dr. Mario Sartori, which is called The War Gases. And he details all the desirable properties of these chemical war agents and the relationship between their chemical use, their chemical structure, and their military use. And I think that's a very revealing book. And in Dr. Sartori's book, there are no nerve agents, because he wrote his book prior to the discovery of the nerve agents. And basically, his book says the agent has to have a severe toxic and lethal effect on humans and animals at very low concentrations, principally affecting the eyes, lungs, and skin. The agent's physical properties have to create a sufficient vapor pressure at ordinary temperatures to be effective, and must persist in the environment to achieve any kind of tactical goal as a chemical agent. And the chemical properties of the agent has to meet stability and non-reactivity requirements when in storage. They have to be stable in explosions, because a lot of these were then put into artillery shells. And they have to be resistant to decomposition by sunlight, water, and other environmental factors. In meeting a lot of these agents, he also said they had to meet an acceptable mortality product at that time called the Haber product, or the lethality index, where milligrams per meter cubed times minutes equaled the lethal index. And this mortality product actually measured the toxic potency of these war gases, and thus created a whole new realm of chemistry, lethal war gas chemistry, resulting in 4 basic types of military causality agents that are present still in modern arsenals. These are the blister agents, the choking agents, the blood agents, and the nerve agents. And that's the military designation of those 4 classes of agents. Each of those contains several different compounds, and we're going to touch on those 4 classes and some of the key compounds in each of those classes. A lot of this is in your book, but a lot of what I'm going to say is not in your book. And so I'll refer you to your book for general reading, but I want to cover some things that may not be in your book. So the field behavior to achieve these effects had to meet the following criteria. They had to cause casualties. They had to decrease an opponent's effectiveness to fight, to move, to occupy territory. They had to restrict a channel or a use of terrain. They had to delay someone's advance. They had to be able to contaminate an area of approach or occupancy, to deny use of a structure, to deny use of terrain, to have the capacity to attack reserves or supplies. And these 4 categories certainly do that. The first category that I'm going to talk about briefly are the choking agents. And we're going to talk about vesicants and nerve agents in just a minute. But one of the primary gases that really was used in World War I was cyanide and cyanogen chloride. Those 2 are in your book. Actually, cyanide was not as successful as chlorine in terms of just the ability to rout people out of places and to cause havoc, because it has a higher volatility and would disseminate in the open environment much easier than chlorine gas would. And that's why chlorine could still be a rather useful agent in an enclosed space. And cyanide is a better agent in the enclosed spaces. But the Iraqis who used cyanide against the Kurds in 1980s found it to be very effective in terms of a lethal agent. Cyanide can be delivered by artillery shells, it can be delivered by bombs or released from canisters. Both cyanogen chloride and cyanide have similar properties, and those are the two agents that are considered the choking agents that could possibly have some kind of terrorist use. When you study the chemistry of cyanide, you have compounds such as sodium cyanide and potassium cyanide. And when these are exposed to water or to an acid, they release cyanide gas, hydrogen cyanide. Many times these crystals of the sodium or potassium cyanide themselves, when exposed to water or gas, is exactly the source of the hydrogen cyanide. And it may not be just a gas released from a canister. It can be a bunch of these crystals put on a floor somewhere or in a place that you're going to wet down in an enclosed space that could then generate this gas and result in people being ill or lethal effects. The lethality of cyanide, basically, if someone receives a lethal dose, they become very quickly dyspneic, short of breath, very short of breath, air hunger, headache, confusion at first. As the concentration increases or as the absorption increases through the lungs or through the skin, seizures, apnea, bradycardia, death can occur. Please, if you have a question anytime, just raise your hand and we'll talk. And so cyanide can be terribly, terribly rapid. It can be used also to put into food, into medications. It can, and also released as a gas. So cyanide is something that could easily be moved around. It's easily found in laboratories. Any kind of pathology laboratory or chemical laboratory uses, at the university for instance, uses cyanide. We have recent episodes of graduate students poisoning themselves because of using cyanide type compounds, mixing them with gases without vapor hoods being available. That happened as of a few months ago at the university. So it's highly available and easy to work with. Cyanide inhibits cytochrome oxidase systems and basically interrupts aerobic cellular metabolism. And that's its main root of toxicity and cause of toxicity. How do you detect it? Well, hazardous material response teams have cyanide, real-time cyanide vapor detectors, and also colorimetric tubes to detect cyanide. Generally, though, it's rather late. You as physicians or hospital-based individuals, how would you be exposed to cyanide? Maybe through someone's contaminated clothes, for instance, or someone just wants to use cyanide crystals to disrupt medical care, for instance, in a number of ways, or lace something with cyanide would be one of the ways you can actually be exposed. Otherwise, what you're going to be doing is treating someone with suspected cyanide poisoning who might come in. So how do you recognize it? Well, basically, someone who's seizing, who is not responsive to bicarbonate therapy, who's not responsive to pressors, fixed and dilated pupils, hard to resuscitate, young person, you have to think of cyanide. And that was the exact presentation of the individuals who were poisoned with cyanide in the Tylenol Chicago murders. Because those individuals were all very young, of the same family, concentrated around in one area, for instance, and refractory just like that to therapy. That should raise suspicions of at least two agents in your mind, cyanide and hydrogen sulfide. Now, hydrogen sulfide is not covered in your textbook, but hydrogen sulfide works basically the same way and binds to the same enzyme systems to interfere with aerobic cellular respiration, and therefore you cannot use oxygen. Hydrogen sulfide, though, has a terrible rotten odor. As we all know, it's a product of sewer gas. However, at a very high concentration, it doesn't have an odor. It causes olfactory fatigue rather rapidly and can result in death. So someone entering an enclosed space where hydrogen sulfide might be present in high concentrations would simply pass out and die. There would not be much warning. Cyanide would basically, at that concentration, do the same thing. There are military kits that are designed to detect and identify chemical agents as liquids or vapors. There's the M256A1 kit that detects cyanide, for instance. You don't have those, and I doubt that you will have those. As I said, cyanide is detectable by real-time monitoring, but when you have a patient who comes into the emergency department, you have to have a high index of suspicion about cyanide. There is a pharmacotherapy for cyanide using what we call the old Lilly cyanide antidote kit. Nowadays it's just called the cyanide antidote kit because I don't think Lilly makes it anymore. And it combines nitrites with thiosulfate. And what you're attempting to do is to create a methemoglobinemia with a nitrite infusion, which then can bind and chelate the cyanide to pull it away essentially from the enzyme systems that it's bound to, and then administer the thiosulfate to further detoxify the cyanide. Since cyanide binds preferentially to methemoglobinemia, this can work if administered quickly. In the cases of the Chicago cyanide Tylenol poisoning, no antidote was given to those individuals, despite the fact that they knew the cyanide levels were sky high because of a controversy about the efficacy of the cyanide kit. Which is a shame because other people have been resuscitated using this kit. There are other antidotes. Hydroxycobalamin, which is a vitamin B12 precursor, and dicobalt EDTA have also been used to prevent cyanide poisoning and also to reverse toxicity. Basically, skin decontamination of cyanide, though, is really not necessary because it's so volatile. but the clothing needs to be removed, and I would still decontaminate someone like that because you don't know what's being used. And someone who is a sophisticated terrorist will use not just one agent, they will use multiple agents. For instance, an explosion may occur in a place that would scatter cyanide crystals all over a place and cause maybe a fire or water damage to a structure, so that when people would go in to bring out the injured, there would be levels of cyanide gas in the air that people would be exposed to. And because it's a trauma scene, no one's wearing a hazmat suit. So this would be a scenario where you could get to the medical personnel who are responding to a trauma, for instance. So it's not unusual that a poison or a biological or a radiological would be used with an explosion, for instance. There may be 2 or 3 things used, sort of a cocktail approach to something like this. And so if you think something like this is going on, think in terms of multiple agents, not just a single one. I think that is quite important. So cyanide is really representative of the choking agent, as that one class of military agents, okay? Any questions about cyanide that I can maybe discourse a little bit further on? Okay, the nerve agents. The nerve agents actually were formulated, the first one by Dr. Gerhard Schrader in 1937. He was a German scientist who was trying to improve pesticides. And he found that highly toxic esters can be obtained when a phosphorus atom was connected in a double bond to oxygen or sulfur. Tabin was the first German agent actually formulated, and there are 3 German agents, and then VX. VX is not a German agent, was actually discovered by the British. But the 3 German agents, GB, GD, and GA, Tabin is GA, German agent, first one. Then we have Sarin, GB, and Soman, GD. The G, of course, as I mentioned, stands for Germans. Dr. Schrader found that the nerve agent Tabin that he created was highly toxic because he poisoned himself and some of his laboratory technicians as they were developing this poison. And he got really excited about it, and he sent it to the Wehrmacht, who then studied this as a war gas. And that's basically how the whole thing started. The VX was discovered by the British in 1952, who shipped it to the United States for further development and production. That was interrupted by the Soviet Union, whose spies found out about the formula, and then the Soviet Union then started developing VX. So that's sort of the basic history of where those nerve agents came from. The important thing about these nerve agents are their vapor pressure, their ability to penetrate through virtually any route of exposure and bind to acetylcholinesterase enzyme systems and other enzyme systems throughout the mammalian body, including animals and man. This causes acetylcholine to accumulate at receptor sites. And when acetylcholine accumulates, because it's not being broken down by the acetylcholinesterase enzyme, you have first stimulation of the receptor sites and then exhaustion of these receptor sites. The stimulation results in 2 broad systemic manifestations of symptoms that we call muscarinic and nicotinic. And the recognition of those broad signs and symptoms will help you diagnose whether or not you're dealing with a nerve agent. Now, common organophosphate insecticides like malathion, parathion, dicyston, diazinon, all of those that you can find at Kmart, Walmart, and all the grocery stores or wherever you're looking, hardware stores, have and act the same way as these nerve agents. They basically have the same pharmacology of binding to acetylcholinesterase enzymes. Consequently, but they don't have the vapor potential of these war agents, nor the lethality factors. And we're going to go over more of these signs and symptoms as we go by, and we take a look at them on the slides. It's interesting that individuals who are poisoned by these organophosphates, these nerve agents, will show the similar signs and symptoms no matter what the route. And for instance, the muscarinic receptors, think SLUD syndrome, S-L-U-D, salivation, lacrimation, urination, defecation. All right, it results in bronchorrhea, so your lungs fill up with fluids. It results in abdominal cramping and pain, tearing, a lot of lacrimation. The individual is basically drowning in their own fluids, and they have diarrhea, and then part of the nicotinic signs and symptoms are the seizures and the musculoskeletal paralysis that occurs. And also meiosis, very small pinpoint pupils. And so it's really not hard to recognize this sort of thing, because these guys have very, very hyperactive vowel sounds along with meiotic pupils, which is different than a narcotic. Just a narcotic can produce pinpoint pupils, but there are no vowel sounds in a narcotic overdose. So a pinpoint pupil with hyperactive vowel sounds is not a narcotic, all right? Especially if you have pulmonary edema. Opiates in an overdose produce pulmonary edema. But if they're going to produce pulmonary edema, they're going to produce no bowel sounds. So a quick differential diagnosis: if you hear bowel sounds, you have diarrhea, pinpoint pupils, pulmonary edema, and neuromuscular weakness with seizures, you better think about organophosphates. Okay. You can have tremors, localized sweating, where the organophosphate actually contacts the skin. The most common cause of death after acute exposure to nerve agents is respiratory arrest. And VX in particular, people exposed to it can just drop down dead very quickly. It's a very rapid acting agent. It's the most lethal of those nerve agents, by the way, and binds to every mammalian enzyme system known. So it can interfere with virtually any kind of enzymatic process, including the acetylcholinesterase. How to, just out of a little history, the cult, the Japanese, what was the name of that cult? The Shim somebody. It's in your book. There was a Japanese cult in 1994, 1995 that used sarin in 2 places in Japan. And if you study that use of sarin, you can get an idea of why these things can be ideal agents for terrorism as well as for creating some lethality. But the Japanese cult, and I apologize for not remembering the name, but it is in your book, and it's on one of the slides too. They chose sarin for a reason, because sarin forms a vapor 36 times faster than any of the other organophosphates, the nerve agents. So it's very rapid in its formation of a vapor pressure. It also is 6 times more dense than air, and so it will go into low-lying areas. They used it at least twice. They used it in the city of Matsumoto in the summer at midnight, releasing it into a humid environment with a little bit of wind that drifted this vapor into the city. And I believe that was sort of a test. And then the next year they used it on the subway. But I think they were just testing this stuff and seeing what would happen. I think a dog died and one other person died. A bunch of people got sick, but that was in the open air. And then they used it about a year later in a subway system in Tokyo, and I forget how many deaths, 18 deaths maybe, something like that. And that's the ideal place to use it if you want to cause both panic and other problems. And in doing that, it was concentrated within a space, because sarin, has no color, no odor. You cannot see its vapor, so you really don't even know it's there. And it makes an ideal agent for that. It's very rapid, and people would look like a bad flu, but it would be a rapid epidemic of bad flu at first, with people passing out and so forth. And again, it would create panic, and that's exactly what happened. And so a lot of the people that did show up at the emergency departments all around came directly to the emergency departments, bypassing the EMS system. And that was part of the problem because these people weren't decontaminated in the field and just were driven by private vehicles to emergency departments. Very much akin to what would happen here. I do not think that the EMS system would be able to contain this sort of thing. So people would show up in mass numbers, a lot of psychological effects, but that's what a terrorist is trying to achieve. They don't necessarily need a bunch of dead bodies. They need enough, and then they need a terrorizing effect, and that's what they try to achieve. And again, one of the reasons they would use multiple agents would be to dismantle or to interfere with the EMS system. And it can happen very easily. You let one or two paramedics or firemen go down at a scene where you think there might be some kind of poisonous gas, and they're not going to go back in there. They're not going to respond. So now you've taken and you've handicapped your EMS system pretty quickly. And so they won't go in unless hazardous material team goes in. And so a hazmat team might go in. So if a radiologic agent has been spread out, in addition to a poison that was thrown about because of an explosion that killed a few people, the hazmat team would receive lethal doses of radiation through their suits also. So that combination is probably an approach that we may see. I don't think we've seen it yet, but you have to be aware of that. How do you detect the nerve agents? Well, basically the nerve agents are detected by measuring red blood cell cholinesterases and plasma cholinesterases. It takes 3 to 7 days to get a red blood cell cholinesterase returned. You cannot get them anywhere in Tucson. I think Casa Grande might do them. And so you're out of luck. So you're going to rely on the plasma cholinesterase. The plasma cholinesterase returns rather quickly, but it can be depressed so severely and be its activity zero, and it can give away that you might be dealing with one of these agents, which would then lead you to go ahead and start administering the antidotes. Well, besides and we're going to get in the antidotes in just a second, besides the acute effects of the organophosphates and these nerve agents, they have delayed effects. Impaired memory, paralysis, insomnia, fatigue, drowsiness, mental confusion, difficulty concentrating, schizophrenic reactions, sudden cardiac failure. Even with an acute poisoning, if you survive it, there may be neurological effects to follow. This is probably because the toxic effects are not solely due to inactivation of acetylcholinesterase, but they do bind to other enzyme systems. The management. First of all, decontamination is a priority. Hopefully this will be done in the field. If it's not, it should be done somewhere outside of the emergency department with a makeshift decontamination. 2 sawhorses, with a stretcher or a swimming pool that you can decontaminate someone in, or just a hose pipe. Simply washing with water and soap will remove a lot of this from the skin, but you have to protect yourself also. So the decontamination is critical. If clothes are contaminated and you are actually touching the clothes and removing them with your bare hands, medical personnel can become victims at that point also. The management is basically really just 3 agents: atropine, protopam, which is pralidoxime, and diazepam. The military likes the use of diazepam a lot. In civilian cases, we don't use diazepam that much. But the military feels that with these military agents, the use of diazepam can be very neuroprotective. And because these are so severe and so dangerous of an agent, then I would recommend the use of diazepam. It doesn't hurt to use it with your garden variety malathion poisoning either. But you're not going to get the kind of severe neurological effects from that kind of garden variety malathion, parathion either. So atropine and pralidoxime for sure. Someone who is showing signs and symptoms, you should give both of those agents. Basically, the atropine has only one function, and that is to block muscarinic receptors. The protopam, the pralidoxime, regenerates the enzyme. It cleaves and takes the organophosphate away from the enzyme. However, if you let too much time go by, there's a reaction called the aging reaction, where you cannot remove that. And the aging reaction occurs very quickly for some and slow for the others. Soman, for instance, ages in 2 minutes. So if you have someone poisoned with soman and it's past 2 minutes, the protopam probably won't do any good. It's bound for life. It's there. VX has an aging period of 60 hours. So it's easier to use it with VX. So it's extremely helpful for some. For soman, it may not be as effective. So that's why the military supplies the troops with self-injectable atropine protopam out in the field. For us here in Tucson, one patient who is severely poisoned, you will use up all the stores of atropine in the city within 24 hours on one patient. So you won't be able to treat anybody else. You can get one of them treated maybe. There's not enough atropine in the city to support a multiple casualty of treatment with an organic. Generally, people will, in a severe poisoning with just a very weak poison like malathion, may use up 2 grams of atropine in 24 hours very easily. And you give the atropine as needed. Your endpoint is drying secretions. That's the muscarinic SLUD, okay? SLUD. Get rid of SLUD with atropine. Block muscarinic receptors, you'll reverse the bronchorrhea, which causes the pulmonary edema, and you'll block the salivation, lacrimation, so forth. And you just give it until you reverse those signs and symptoms. It's very difficult to get physicians to give that much of this stuff. They're very reluctant, even in a poisoned patient, to administer that much atropine. But you have to in order to reverse those signs and symptoms. You'll know whether or not you reverse them when you make them toxic with the atropine. But people don't die from atropine poisoning, they die from organophosphate poisoning. So atropinize them. Endpoint is drying secretions. At the same time, you want to go ahead and administer the protopam intravenously. And order it up, take a gram of it, give it intravenously over 20 minutes. You can either give it as a continuous infusion or you can give it as bolus doses, but you're going to have to give a bunch of it. As I said, we may end up using most of that in the city if we have a bad case, a bad poisoning case. So just be aware of that. There isn't enough. And then the diazepam, of course, helps prevent seizures and the neurological damage from these organophosphates. So you want to control the airway, control the seizures, control the SLUD syndrome. Someone who is given just atropine can die a respiratory death because atropine doesn't block nicotinic receptors, only muscarinic receptors. So the nicotinic receptors are the skeletal muscles of respiration. So somebody could be sitting there nice and dry, not breathing. So you know, you got to really remember that. And I've seen that happen with children especially because they're real quiet and they're under the covers. And then they can't move. They're paralyzed. They're not moving. And I watched a kid go out of an ICU one day with a chlorpyrifos, which, by the way, you put in your slabs for termites, with a chlorpyrifos poisoning, completely dry after the atropine. He was so cute lying there, and he couldn't sit up. He couldn't move to sit up. And that's part of the problem with children. So the nicotinic symptoms may predominate, and you may see nothing but a neuromuscular paralysis in children. So at least be aware of that as they might be a victim of some of this. Okay, now this what I'm going over is not in your book. Decontamination we talked briefly about. This is in your book. It's accomplished with soap and water. If you don't have soap, use water. You can take household bleach and you can dilute household bleach 1 to 10. 1 part bleach, 10 water. Just dilute it. Don't use it full strength. And that will also hydrolyze, help break down the organophosphates, except for tabun, which forms cyanide in the presence of bleach. So if you think for some reason it's tabun, a bleach solution might actually release some cyanide. But you won't know that it's tabun. So soap and water is basically what you want to use. Just briefly going, by the way, wounds should be copiously irrigated with water and soap also. Don't pour the hypochlorite solution into eyes. And just use saline, soap, and water, and you'll be okay. And with these kind of situations, healthcare providers should wear protective gear. And we have a speaker later on that's going to tell you how well we're prepared in our community with this protective gear. And get into that somewhat. But briefly, tabin. Pale to dark amber liquid, gives off a colorless vapor. Has an odor of rotting fruits. And the half-life in the environment is 1/2 a day to 1 day, so it can persist. It's the least vapor hazard of the nerve agents and can persist in shaded areas for days versus sunlight areas much shorter. Sarin gives off no odor, colorless vapor. It was the second of the war agents discovered by Dr. Schrader in 1938, and actually its initials come after the colleagues who were involved in its formation. It's 10 times faster than tabin in killing animals. Production was delayed in World War II and was completed in 1945 after the Russians captured the facilities that the Germans were manufacturing this. As I said, it's the most volatile of the 3 German war agents, forms a vapor mass 36 times faster than tabin, and it's 5 to 6 times more dense than air. Soman, or GD, was the last of the 3 German war agents to be developed. 50 milligrams is the median lethal percutaneous dose of Soman, and it binds very tightly to acetylcholinesterase, and as mentioned, if you don't treat with pralidoxime within 2 minutes, you will not reverse that binding. It has a persistency, Soman does, in the environment of 1 to 2 days. Its vapor density is 6.5 times that of air. The VX is, there are other V war agents, but VX is the prototype. There was one called VR55, but had no further toxicity than VX, so VX is the one that has been used and developed. It's the most toxic of the nerve agents. It's odorless, pale amber liquid, and gives off a colorless vapor, discovered in 1952 by a British scientist who was trying to replace DDT and discovered VX. This formula, as I mentioned, was intercepted by the Russians when they were shipping it to the Americans, and so they were able to get VX. Production in the U.S. was halted at around 2.5 tons in 1968, but 20 pounds leaked from an aerial spray tank in Utah in 1968 and killed 600 sheep. It reacts with virtually every mammalian enzyme system. And it was designed to create casualties via dermal absorption, so it's mostly a dermal agent. Death from dermal absorption occurs with 0.001 grams, so 1 milligram. Low volatility and low vapor pressure. Okay, the choking agents. Let's see, we want to, okay. A couple of these are worth mentioning because they were used in World War I, phosgene and chlorine, as I had mentioned. Those were the 2 main agents that would cause respiratory problems, eye burning, and skin irritation. Chlorine is water soluble and a yellow-green gas, 2.5 times heavier than air. And they released, the Germans did, around 500 tons of chlorine from over 20,000 cylinders April 22nd, 1915, and caused 7,000 casualties in Belgium. It was easy to detect because of its color and its irritancy, so they abandoned that and went to other agents. When chlorine meets water, mucous membranes, and you inhale it, it forms both hydrochloric and hypochlorous acids on contact. And that's basically what causes the injury. It causes inflammation of the upper airways and of the lungs, and can disrupt cellular proteins because of its corrosive effects and free chlorine formation. So chlorine irritant toxicity is irritant. So you've all seen it from pool supply companies releasing it in town and so forth and sending people to an emergency department, so you know what it can do. At up to 3 parts per million, it's mildly irritating. At 30 parts per million, you have onset of chest pain fairly quickly, dyspnea, cough, severe respiratory distress. Over 400 parts per million, it's potentially lethal, and over 1,000 parts per million, it's fatal within minutes. You basically have to remove someone from exposure, decontaminate with copious irrigation of water, provide high flow of oxygen. We've used nebulized inhalation of a mixture of 2 mLs of sodium bicarb with 2 mLs of normal saline in our emergency department before to symptomatically treat people, and it seems to work. That's not in that book either, but that can provide some symptomatic relief. Again, it's basic management. You can get pulmonary edema from chlorine, you can get severe bronchospasm, and people can become very sick, of course. Phosgene is the other agent, carbonyl chloride, which was actually synthesized first in 1812. It's a very deadly agent. The British used it, the Germans used it. It was highlighted in All Quiet on the Western Front when the tragic effects of phosgene gas were described in a dugout full of people with blue heads and black lips. Some of the troops in the trenches took off their mask when they noticed the troops above the trenches taking off their masks, not realizing the phosgene was just pouring down into the trenches. And so when they took off their masks, watching those guys take theirs off, because this stuff flows in the low-lying areas, they were severely poisoned. So it was a mistake to follow your colleagues. And it's very well described in that book. It's transported as a liquid, and it exists as a gas above a temperature of 47 degrees Fahrenheit. So it's ideal in forming a cloud. The cloud is usually a white cloud. It's heavier than air, has very poor water solubility, and that's very important. Things with poor water solubility will penetrate down into the lower lungs much easier than things with higher water solubility. The higher water solubility agents go into the nose and mouth and basically stay there unless you're overwhelmed in an enclosed space. But phosgene can penetrate into the lower areas of the lungs. It produces an immediate irritation, but does not cause immediate lung damage. That comes later. So it's a very insidious hazard. So you might get skin and eye and throat irritation from it, but a person can have a lethal dose of phosgene and not know it. And then later on, the pulmonary symptoms and signs begin. And that's critical. Again, anyone in a low-lying area is at more of a hazard. Phosgene gas vapors are also explosive. It dissipates in the open and in sunny areas, but in shaded areas or in low-lying areas can persist over 10 hours, particularly in the low-lying areas, and if the temperature is below 70 degrees Fahrenheit. So basically toxicity is as follows: bronchospasm, dizziness, chest tightness, coughing, choking, pulmonary edema, hypotension, and eye burning. Low concentrations will cause pharyngitis, burning of the skin, dyspnea, mucous membrane irritation, and so forth. And then after a latent period, which can be as short as 2 hours or as long as 24 hours, pulmonary edema develops. Frothy sputum does not cause hemorrhage of the pulmonary tract. So if you have someone with hemorrhage, you might be dealing with mustard instead of with phosgene, for instance. So decontamination is with copious amounts of water, which will decompose phosgene. That's why it doesn't last in humid environments as well. Medical providers need to be appropriately protected, and decontamination stations well ventilated for this gas. Management is supportive, then there is no antidote, of course. The Germans also developed something called diphosgene, which is similar to phosgene. It was created after World War I to improve on phosgene. It's basically phosgene with chloroform attached to it. Diphosgene is not in your book, by the way. So diphosgene is something that is available, but it tends to break down. It's stored in glass because in metal it oxidizes. Also, diphosgene vapors are not explosive. The next one we're going to talk briefly about are the blister agents. The third category, I think it's the third category. Now this is the fourth category. The blister agents or the vesicants, the choking agents, the blood agents, the nerve agents, and then the vesicants or blister agents. These are known as vesicants because of their blistering effect on the skin, eyes, and lungs and mucous membranes. The most commonly used vesicant in World War I was mustard. The other most important vesicant you should know about is something called lewisite, or arsine. It's an arsenical gas, an arsine vesicant. These agents basically produce burns on exposed tissue, but also can penetrate through the skin and cause systemic toxicity. The mustards, as a group, form toxic cyclic compounds that alkylate tissues, alkylate and bind to DNA, and therefore they can have severe effects also on bone marrow, just like alkylating agent you would use for cancer, because the mustards were used as alkylating agents for treatment. So the mustards can have severe effects on both local contact points, the eyes and skin and lungs, but can be systemically absorbed to cause their most severe toxicity. They have a long persistency in the environment and are very insidious poisons, and they have no odor and no pain on initial exposure. However, there is one, lewisite, that you should remember does have immediate pain on exposure, okay? And lewisite is the other vesicant agent. There's a lot of vesicants. I'll just read you some of the names of those that have been developed. There's the mustards, which is distilled mustard. The arsenicals, methyl dichloroarsine, phenyl dichloroarsine, ethyl dichloroarsine, dichloroarsine or lewisite. The nitrogen mustards, the oximes, which is phosgene oxime. Then there's mustard mixtures of lewisite and mustard tea, and they're obsolete mustard or obsolete blister compounds which aren't used anymore. So several of these are available. The formulas for making these are all in this 1939 book. So anyone who has this book, which is in the library, can chemically make any one of these agents. However, most of the ones that are available, the mustards and so forth, are usually already stockpiled as chemical warfare agents. They receive their name from their garlic-like pungent smell, mustards, and they've been known as Ypres after the location of the first battle where it was used in Belgium, Ypres, and then the Allied soldiers called it Hun stuff because the Germans used it. So those were its, it was also most recently employed during the Iran-Iraq conflict where mustard gas was used. It's a clear yellow or amber-colored oily liquid with a faint garlic odor, slightly soluble in water. And as I said, it causes alkylation of DNA, and it can pass through ordinary clothing, and the systemic toxic reaction can be delayed for about 16 to 24 hours. It's mutagenic, carcinogenic, and teratogenic, and will depress bone marrow, gastrointestinal cells, rapid dividing cells, just like radiation. Skin toxicity of the mustard appears within 2 to 24 hours, and stinging, pruritus, generally in the exposed areas of the face and neck. Large bullae can be formed, and there are photographs of that in your book. Blister fluid does not contain toxic mustard agents and is not secondarily hazardous, by the way. They're deceptive, the burns. They can be deeper than you think, and can produce mustard can produce very dramatic inflammation of the lungs, sloughing of the lung tissues, and pulmonary hemorrhage occurs. But in this case, pulmonary edema is rare, just the opposite of phosgene. Eye injury, keratoconjunctivitis, corneal clouding. Rapid decontamination is critical, especially of the eye, to prevent this kind of injury from occurring. Death occurs from a combination of burns, respiratory damage, hypoxia, pulmonary hemorrhage, and then later on bone marrow suppression with secondary infections. Treatment is basically supportive after decontamination, but decontamination to be effective has to occur in a few minutes following exposures. Because it's an oily liquid, it can form little globs around clothes and skin and so forth. So you have to be really, really careful. Decontamination, again, is with 0.5% or 1 to 10 dilution of household bleach, 0.5% hypochlorite solution. If you delay decontamination, you're not going to alter the clinical course of the patient. Also, decontamination helps protect medical staff from cross-exposure of this oily agent that can be on the skin. The next group of compounds, because there are tons of these gases, and the nitrogen mustards and so forth, lewisite, let's basically say something about lewisite. It's a brown amber liquid, colorless vapor. It differentiates itself from the mustards by causing immediate pain. It was named after Dr. Lewis and discovered in 1904, and was called lewisite because of that. The antidote to this is called British anti-lewisite, or BAL, which you probably recognize as an antidote for heavy metal poisoning, BAL. And so BAL was actually used as an antidote to help bind the arsenic in this toxin. It's rapidly absorbed by the skin, eyes, and lungs, and is very highly irritating on initial exposure. It causes pulmonary damage, does not cause bone marrow suppression, and it can damage the eyes, causing keratoconjunctivitis, edema, and ocular damage. And a skin contact of only 5 minutes can cause a severe chemical burn. And it interacts with thiol groups, sulfur groups, sulfhydryl groups on proteins, which is what arsenic does, metals like that bind to protein. 7 times heavier than air. So it can be used in enclosed spaces or trenches or underlying areas, and can cause blindness. And there is an antidote, as I mentioned, British anti-lewisite. The next agents, the riot agents, we recently had an episode of a death which is debated to be whether or not it's secondary to these lacrimator agents or tear gas agents. There are known deaths from these agents that have occurred, by the way. So it's not unusual to think that there could be a death. I don't understand why not. Because in an enclosed space or so forth, it can cause enough problems such as bronchospasm or dyspnea to result in death. And as I said, deaths have been reported from these agents. These riot control agents, there's basically several of them: CA, CS, CR, CN, CNC, and CNS, and OC. You'll only see a few of those in your book, but that's a whole list of these different agents. So there's a lot more than just 1 or 2 of them. They're used to just disperse crowds, and or to drive grizzly bears away from your campsite if they get too close and aggressive. And decontamination basically is, the basic treatment is supportive, decontaminating the skin, the eyes, any respiratory support. CS, malonitrile or tear gas, is the current standard riot control agent used by the armed forces. And symptoms of exposure are nasal and ocular discharge, photophobia, burning sensation of mucous membrane. It causes an intense release of bradykinin, which is an agent that can increase pain within the body. Extreme irritation of the skin. CN is the standard tear gas used by local law enforcement agencies are mace. And similar effects to CS, but milder. Let's see, CR, which is a very potent lacrimator, was developed in Great Britain in 1962 as an alternative to CS and CN. 10 times more effective than CS. And then CA is a highly irritating agent similar to CN. And, but as I said, those other agents generally are not used. There are some other agents which are kind of interesting, again, which are not covered in your book, which you may have heard about. One of them is called chloropicrin. And it was used as a war gas in 1848. And when it was first developed, rather, in 1848, but used as a war gas in World War I in 1916 in hand grenades. And it's used as a fungicide and a pesticide now. So it finds commercial uses, but it is an original war gas, so its availability is there. Chloropicrin is relatively stable and has a density of 6 times that of air, and is one of the components of CNS, which is an older tear gas agent. So it has intense lacrimating and vomiting effects. There are other agents which we won't get into, such as flame agents, fuel oil, napalm, and so forth. But I think we've sort of covered the basic agents that most likely will be something that you might see. I'm just looking to see if there's anything else that's kind of funny that somebody might use, but there's a lot of common chemicals that can be used, though, as terrorist weapons, and it may not just be these. And, you know, to things that are just common pesticides that can fill an enclosed space and cause, you know, severe injury and death, like carbon monoxide or phosphine gas or arsine gas, which is used for semiconductor manufacturing. All of these can be quite poisonous and quite lethal. So if you focus just on these, you might miss some of the more common things. And most of these terrorist groups, I think, are fairly smart. They know these courses are going on, and they're the type that would think, well, we're going to use something that is fairly common to a community, that can move into a community and not be suspected, something like arsine, for instance. So with that, how am I on time? Am I late? Am I over?
You have approximately
5 minutes. Well, I'm not going to show any slides because the slides are in your book, and I tried to cover these agents and give you some things that are not in your book. So maybe I can just answer some questions if you have any questions right now. There you are. Any questions about any of the chemical agents that we've covered, or any other chemical agents that might come to mind? One of the things that you should do is check your facilities for your protopam, your atropine, and your cyanide antidote kits, and for ability to set up decontamination outside of your facilities, and for your personnel protection for your facilities. If you just do that alone, you've gone a great ways into being prepared, more so than most people are. Yes, Jane?
What is the situation with personnel protective gear at the present time, and what should be done about it?
Kathy Kanak is going to speak on that and talk about the OSHA requirements, what is mandated by OSHA, where we're all falling behind in the community, what an emergency department or hospital facility by OSHA must have, but what do we really have might be two different things. And she's an industrial hygienist who works for UMC and is going to talk about JCHO requirements, OSHA. I guess you're going to cover JCHO too, and the personnel protective equipment in just a little bit. Okay, well, thank you.